Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 357 of our pharmacotherapy series, which majors in asthma. The next case reads, PWN is a 52-year-old man with mild persistent asthma. His asthma symptoms began when he was 2 years of age, and he has never smoked. PWN has had numerous drug regimens for his asthma during the years, but he tells his physician that he wants the simplest regimen possible and that he prefers oral medication if at all possible. So my question to you reads, what is a good choice for controller therapy in PWN? In patients of any age with mild persistent asthma, and certainly in children or adolescents, an oral agent such as montelukast with once-daily dosing at bedtime, or zafirlukast with twice-daily dosing, has obvious advantages. Xelutin is another leukotriene modifier, but it has more drug interactions and adverse effects than the other available agents. An inhaled corticosteroid is the preferred treatment for mild persistent asthma. Studies comparing inhaled corticosteroid with leukotriene receptor agonists have consistently demonstrated the superiority of inhaled corticosteroid for most asthma outcome measures, but in patients, adults or children, who much prefer oral therapy to inhaling medication every day, leukotriene modifiers are a reasonable option. The simplest and safest possible oral controller regimen for PWN is montelukast 10 mg at bedtime, with PRN inhaled albuterol. Bedtime dosing with montelukast is recommended because it will have peak activity late at night and in the early morning hours, when asthma symptoms tend to be more frequent. However, montelukast may be taken at any time of day as long as it is taken at a consistent time that is convenient for the patient. It is likely that this regimen will result in very good asthma control. If PWN does not have good control of his asthma when he returns to the clinic in a few weeks, switching to a low-dose inhaled corticosteroid in the evening only would keep the regimen simple while enhancing efficacy. The next case reads, KJL, a 14-year-old, 40 kg girl, has a history of recurring cough and wheezing. These symptoms worsen on vigorous running or when she has an upper respiratory infection. She has not required hospitalization for these symptoms but has missed a few school days. She has symptoms daily and uses her albuterol inhaler more than 2 times daily. KJL has a family history of asthma. A diagnosis of moderate persistent asthma is made. So my question to you reads, how should KJL be managed? Because KJL has moderate persistent asthma, treatment with an anti-inflammatory agent is indicated. A medium-dose inhaled corticosteroid or a low-dose inhaled corticosteroid plus a long-acting inhaled beta-2 agonist is the preferred treatment in a 14-year-old child with moderate persistent asthma. However, not all healthcare professionals follow the latest evidence-based guidelines, and KJL's clinician opts to prescribe theophylline in combination with a low dose of budesonide via the FlexHaler. My next question to you reads, what dosage of theophylline is appropriate for KJL? Low doses of budesonide combined with twice-daily theophylline that resulted in a median serum theophylline concentration of 8.7 micrograms per milliliter was superior in efficacy to high-dose budesonide as single controller therapy. Thus, it is wise to give a therapeutic trial with low-dose theophylline initially, aiming for serum concentrations between 5 and 10 micrograms per milliliter. Accordingly, the initial dosage in KJL would be 300 mg per day in divided doses, i.e., 150 mg every 12 hours. If tolerated, the dosage is increased at 3-day intervals by about 25% to the mean dose that usually is needed to produce a peak theophylline serum concentration between 5 and 10 micrograms per milliliter. The final dosage can be adjusted by serum concentration monitoring. Serum theophylline concentrations should be obtained at steady state, i.e., when there have been no missed doses and no extra doses have been taken for at least 48 hours. KJL now complains of headache and difficulty in getting to sleep. So my question to you reads, why should a theophylline serum concentration be evaluated? Theophylline side effects can be related to excessive serum concentrations, or adverse effects can be transient and unrelated to the amount in serum. Unfortunately, it is not always possible to determine which it might be. Side effects can include headache, nausea, vomiting, irritability or hyperactivity, insomnia, and diarrhea. With higher serum theophylline levels, cardiac arrhythmias, seizures, and death can occur. Less severe symptoms may not be present before the onset of cardiac arrhythmias or seizures and cannot be relied on as a forewarning of these more serious adverse theophylline effects. It is important not to ignore any symptom consistent with theophylline toxicity. The insomnia and headaches experienced by KJL may not be associated with excessive, i.e., out of the usual therapeutic range, serum theophylline concentrations, but a reduction in dosage should be contemplated because some patients experience toxicity when serum theophylline concentrations are within the therapeutic range. Guidelines for managing toxicity have been revised. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 358.